So in this lecture we are discussing about the thyroid disorders in pregnancy, and first we will discuss the thyroid physiology in pregnancy. So on maternal side, thyrotropin releasing hormone is secreted by the hypothalamus and which acts on the anterior pituitary thyrotrop cells to release the thyroid stimulating hormone or the TSH. Normally in pregnancy there is no thyromegaly or goiter, but if it is there then it wants evaluation. TSH receptors are cross-stimulated, means the structure of receptors for human chorionic gonadotropin, that is HCG, and the thyroid stimulating hormones are similar. So these thyroid receptors are stimulated by HCG also, and in pregnancy, as we know that the quantity of HCG is massive, so this causes stimulation of thyroid stimulating hormone receptors, and because these receptors do not cross the placenta and TSH do not cross the placenta, so it has no direct effect on the fetal cells. Now this stimulation through HCG leads to a decline in the TSH levels because of negative feedback, and in first trimester there is decline of around more than 80% in the pregnant women. The thyroid gland boosts the production of hormones by 40 to 100% to meet the maternal and fetal needs. So because the demands are more and the production is less, so in turn there is enlargement of the thyroid gland, but it is not significant to cause goiter. In first trimester, thyroid binding globulin is also increased and it reaches its highest value at about 20 weeks of gestation, and the concentration stabilizes at approximately double baseline values for rest of the pregnancy. So there is increased level of thyroid binding globulin, and because serum T3 and T4 levels, free T3, free T4 levels are high, so these thyroid binding globulin binds to the free thyroid hormones, and there is increase in total thyroid hormones, but the free thyroid hormones remains within normal range, and because of cross stimulation TSH value is on the lower side. During first trimester, maternal HCG serum levels are maximum and thyroid hormone secretion is stimulated. High levels of serum free T4 levels act to suppress the HPO excess and in turn limits pituitary TSH secretion, and TRH is undetectable in the maternal serum. Total serum T4 levels rise sharply beginning from 6 to 9 weeks of gestation and reaches a plateau at 18 weeks. Serum free T4 levels rises slightly and peak along HCG levels and returns to normal. So this is the chart, and why this thyroid binding globulin is increasing in pregnancy, because in pregnancy there is increase in the estrogen levels. This estrogen levels increases the hepatic production of thyroid binding globulins, and there is increase 2 to 3 fold increase in the production, and because this thyroid binding globulin binds to free T3 and free T4, so the total T3 T4 levels are high, and the total T4 is 1.5 times of the non-pregnant range. And because we have already discussed this, that because the structure is similar to HCG receptor, TSH receptors are cross stimulated by HCG releasing increased T3 and T4, and that because of the negative feedback, that is at 18 to 14 weeks serum TSH levels are on the lower side. And these free T3 free T4 binds to thyroid binding globulin to make a stable total T3 T4. Also there is increased peripheral metabolism of the thyroid hormones, and hence the thyroid hormones remains within the normal range. Because of increased plasma volume, the concentration of thyroid hormones is on the lower side, and fetus thyroid glands matures by 12 weeks of pregnancy. So up to 12 weeks thyroid hormones for fetal functioning are made through the maternal thyroid gland, so the demand is more and the demand value is increased by 30 to 50%. So this is the physiology of HPO excess, that is hypothalamus through the paraventricular nuclei releases thyroid releasing hormone which acts on the thyrotrop cells of anterior pituitary to release TSH. This TSH acts on the thyroid gland which is present in our neck, and the follicles are stimulating, circulating levels of free T3 T4 are released, and they may be bound to the thyroid binding globulin and the albumin. Now these peripheral conversions are occurring, that is T3 to T4 is formed, and this T3, which is an active form of thyroid hormone, acts on the target tissues via nuclear receptors, and these thyroid hormones are excreted through kidneys, and liver conjugation also helps for excretion of these thyroid hormones. Now there is one antibody named as thyroid peroxidase antibody. This is seen in cases of hyperthyroidism and hypothyroidism also. Thyroid peroxidase antibody is formed against thyroid peroxidase enzyme, which is needed for proper thyroid function. So these thyroid antibodies, TPO antibodies, can lead to early pregnancy loss and preterm delivery, and if these antibodies are present in the pregnant women, then there is high risk of postpartum hemorrhage and postpartum thyroiditis, and patient may need lifelong thyroid treatment in 15% of the cases. Now coming to disorders of thyroid gland, the thyroid disorders can be divided into cases with hyperthyroid features and cases with hypothyroid feature. Hyperthyroidism, also known as Graves' disease, GTT, also known as gestational transient thyrotoxicosis, overt hypothyroidism, subclinical hypo and hyperthyroidism, euthyroid, autoimmune thyroid disease, postpartum thyroiditis, and nodular thyroid disease. So this is according to Indian Thyroid Society guidelines 2012, that the level of thyroid stimulating hormone is taken in a reference range. So for first trimester, the level should be less than 2.5 milli international unit per liter. In the second and third trimester, the levels are less than 3 milli international unit per liter. And this is in accordance with the European Thyroid Association guidelines also. But according to ATA means the American Thyroid Association 2017, it says that we have to use the locally derived reference ranges and from a specifically pregnant population, and if these levels differences ranges are not available, then we can use the upper TSH reference limit for 4.0 milli international per unit. Now what are the features of hypothyroidism or Graves' disease? The hyperthyroidism or Graves' disease leads to thyrotoxicosis, means serum TSH levels is very low, and the serum TSH levels is very low, and serum TSH level is low, and serum free T3 and free T4 levels are very high, and the incidence is around 0.4 to 1.7% of birth. So what are the signs and symptoms? The signs of thyrotoxicosis is resting and fine tremors, hyperreflexia causing resting tachycardia, atrial tachyarrhythmias or atrial fibrillation, enlarged painless thyroid with thrill and bruit, warm, moist, smooth skin, hair loss, mood swings, onycholysis, also known as plumber's nail, gynecomastia in male population, and local dermopathy, which is pretibial myxedema that can be seen in hyperthyroidism, thyroid acropathy or exophthalmos, stare, lid glag, retraction, proptosis, which are the ocular signs of Graves' disease. Now the symptoms can be irritability, anxiety, tremors, proximal muscle weakness, difficulty in sleeping, palpitation, blurring of vision, diplopia, heat intolerance, weight loss despite proper diet, increased appetite, frequency in loose stools, menstrual irregularity, and decreased libido, erectile dysfunction, and photophobia, gritty eye, and sensation in dry eyes. So these are the symptoms. These are the ocular symptoms. You can see proptosis, which is exophthalmos. There is lid retraction. Usually the upper lid covers till the margin of the pupil. But here there is lid retraction, that is upper lid is going backwards, and periorbital edema can be seen. Tearing often made worse by cold, wind, bright light exposure. There can be a gritty or foreign object sensation in the eyes. There is blurring of vision, eye or retroocular pain, restriction of the eye movement, diplopia or double vision, and color vision saturation. So there is one classification system that we use for Graves' disease, and this is Keith Wagner classification system. Now the symptoms of Graves' disease can be palpitations, facial flushing, weight loss, palpable lymph nodes can be seen in case of thyroiditis, shortness of breath, breast enlargement, warm velvety skin, muscle wasting can be seen. The pulse rate is high, that patient can present with tachycardia, warm and moist palms because the basal metabolic rate is high. Oligomenorrhea and amenorrhea can be the menstrual complaints of the patient. Local myxedema means there is increased in fluid content in the pre-tibial area, and muscle weakness, fatigability can be seen, clubbing of fingers, and this is seen in patients of severe exophthalmos. There are resting tremors, Diarrhea because of increased bowel activity. Patient can present with loose stools, increase in appetite, palpitation and tachycardia. Goiter can be seen where the thyroid gland is enlarged, and you can see a midline neck mass. Exophthalmos, which is the protrusion of the eyeballs, and patient can present with nervousness, excitability, restlessness, emotional instability and insomnia also. So how will you make a diagnosis of hyperthyroidism? So in hyperthyroidism, the serum TSH level is depressed, that serum TSH levels is less than 1, and the serum free T4 T3 levels are very high, and because T3 is the main active thyroid hormones, so you can see an abnormally high serum T3 levels known as T3 thyrotoxicosis. And because in Graves disease, which is an autoimmune disease, so antibodies can also be seen. And what antibodies do we encounter? These are the TRAB antibodies, that is thyroid receptor antibodies, and patient can be a known case of overt hyperthyroidism. TSH is suppressed and it is less than 0.1 milli international unit per ml, and it can also be undetectable. So the free T4 and free T3 levels are elevated, and they are more than 1.5 times the upper limit of normal of a non-pregnant patient. While when you check the total T3 T4 levels, they are also elevated. TRAB antibodies are present, and the disappearance may indicate remission of a Graves disease. So according to ATA guidelines, thyroid receptor antibodies should be checked in women with anti-thyroid medication and elevated TRAB levels, or who continue therapy. Repeat testing is recommended between 18 to 22 weeks of gestation. So what are the causes of this hyperthyroidism? This can be Graves disease, which is an autoimmune disease. This thyrotoxicosis can also be encountered in gestational trophoblastic disease. And why it happens? Because there is increased level of beta SCG in gestational trophoblastic disease or the molar pregnancy, and this SCG in the early weeks of gestation, and because this molar pregnancy gets aborted in the early weeks of gestation, so this increased SCG stimulates or cross stimulates the thyroid receptors, and hence in turn causes the thyrotoxicosis. In hyperemesis gravidarum, this hyperemesis gravidarum also occurs because of more SCG, and this also carries the same physiology, and this could also be due to drug induced causes. So what are the pregnancy outcomes and the fetal effects in case of hyperthyroidism? So in for maternal effects, there could be high risk of miscarriage or abortions, risk of preterm birth is there, preeclampsia is there, risk of heart failure is there, risk of hyperemesis gravidarum, and thyroid storm can also be seen. While the fetus can have fetal goiter, fetal hypothyroidism, growth restriction in the fetus, stillbirth, high drops, and tachycardia. So the ATA guidelines tells that the umbilical cord sampling only be considered when the fetal goiter is detected and the thyroid status of the fetus is unclear. So if there is female of hyperthyroidism, so ATA suggests that we should measure the serum thyroid levels in the umbilical cord sample for the suspected case of fetal goiter. Now what is the treatment of hyperthyroidism? So the mechanism of action decides the management plan for hyperthyroidism. So we can prevent the hormone synthesis either by inhibiting thyroid peroxidase enzyme. What this thyroid peroxidase enzyme do? It helps in the formation of thyroid hormone. We can also block the iodine organification. We can block the coupling of iodotyrosenes and inhibit peripheral deiodination of T4 to T3. So we can inhibit the conversion of T4 to T3, which is an active form. And since synthesis rather than release of hormone is affected, onset of action is slow and it requires around 3 to 4 weeks before stores of T4s are depleted. So if we are starting drugs based on these mechanism of actions, then after starting the drug, the hormone, the effect can be seen 3 to 4 weeks after starting the drug. So this is the physiology. So what happens that inside the thyroid gland or inside the thyroid follicle, this iodine is getting transported, and under the effect of peroxidase enzyme, this iodine I minus or the iodine ion is converted to I2, which is the form of iodine which is getting bind to the thyroglobulin hormone. So this I2 binds to TBG or the thyroid binding globulin hormone and forms MIT-DIT T3 T4. Now these MIT-DIT complex undergoes proteolysis to form T4 and T3 and which are released into the blood. Now these T3 and T4 reaches the peripheral tissues where they are getting converted to T3, and this T3 is the active form which is going to act. So there are drugs which can be acting on the various mechanisms that this thyroid gland is undergoing. So the first drug is thioamides. So what these thioamides do? These are the thyroid peroxidase inhibitor drugs, and these drugs inhibits the conversion of I- to I2. Now the iodides and thioamides prevents the formation of MIT-DIT complex by inhibiting the binding of I2 to thyroglobulin. Then there are proteolysis inhibitors. So these iodides have dual action. They also inhibit proteolysis. And for peripheral conversion, we can give the beta blockers, the amiodarons, thioamides, and iodinated contrast medias. So this is the physiology. Now on the second diagram, you can see there is inhibition of thyroid peroxidase enzyme catalyzing the iodination of thyroid residues. Then effect on intrathyroid lymphocytes and immune system. The thyroxine is getting converted to, means T4 is getting converted to triiodothyronine, and this conversion is blocked by propiothiouracil or the PTU. Methimazole blocks the conversion of thyroxine to triiodothyronine in the peripheral tissues. So what is the treatment? Thyrotoxics during pregnancy can near always be controlled by thionamides drug. And what are the thionamides drug? Thionamides drugs can be propylthiouracil, methimazole, and carbimazole. And because carbimazole is not given in pregnancy, propylthiouracil is the preferred drug in the first trimester up till 16 weeks as compared with the tab methimazole, because in the first trimester organogenesis is occurring, and this methimazole is associated with embryopathy, and it can lead to choanal atresia, esophageal atresia, aplasia cutis, and aplasia cutis, a congenital skin defect. So in the first trimester of pregnancy, propylthiouracil is preferred because it does not lead to congenital side effects. While because this is very hepatotoxic, so this propylthiouracil need not to be continued in the second and third trimester. In the second and third trimester, we start the patient on methimazole, and for non-pregnant patient, the ATA recommends that methimazole initial dose is 10 to 20 milligrams. So starting dose is 10 to 20 milligrams, followed by a maintenance dose of 5 to 10 milligrams, और टैप प्रोपाइथायोरसिल का डोज क्या होता है 50 to 150 milligrams TDS. तो PTU is given in a dose of 50 milligram TDS, while the dose of methimazole is 10 to 20 milligram followed by 5 to 10 milligrams. TAP PTU 300 to 450 milligrams orally daily in 3 divided doses. This can also be the answer. And when we are switching from propylthiouracil to methimazole, then the dose ratio is 20:1. And because these are the drugs which helps in inhibiting the synthesis of thyroid hormones, so a more dose of propylthiouracil is needed at the time of switch. Now what is the goal of treatment? So the goal of treatment is to make the lowest possible thionamide dose to maintain the thyroid hormones levels slightly above or in the high normal range when the serum TSH is suppressed. Serum free T4 concentrations are measured every 4 to 6 weeks, and if there is very much enlargement of the thyroid gland and there is thyrotoxicosis also, which is not which we are not able to control by medical treatment, then subtotal thyroidectomy can be performed. And before performing subtotal thyroidectomy, the disease should be medically controlled, and the surgery is best accomplished in the second trimester. So any surgery which is needed in pregnancy is to be done in the second trimester. And what is the drawback of surgery? That it can lead to inadvertent section of the parathyroid glands that are present at the periphery of the thyroid gland, and the recurrent laryngeal nerve also passes through this parathyroid gland. So the injury to RLN or the recurrent laryngeal nerve can also occur. Thyroid ablation and radioactive iodine exposure is contraindicated in pregnancy because it can lead to fetal complications also. Antithyroid medications may be used safely during lactation, and thiazide should be given after the feed. So thiazide drugs means propylthiouracil and the methimazole are given after having meals. The recommended dose, carbimazole usually not preferred, but we can give methimazole up to a dose of 20 milligrams per day in divided doses, propylthiouracil up to 300 milligrams per day, and carbimazole which starts with C. So C is the third alphabet, so the dose is 30 milligrams per day in divided doses. So 30, propylthiouracil is 300 and methimazole is 20 milligrams per day, and all are divided into 3 doses. So here are the anti-thyroid drugs, their side effects and the monitoring of doses in pregnancy. So the propylthiouracil can be started 50 mg to 150 mg TDS or in a total dose of 300 mg per day. It is recommended in the first trimester. It can cross placenta, but it has lesser side effects which are fetal. Side effect of propylthiouracil can be hepatic failure or hepatic dysfunction and agranulocytosis. The dose of carbimazole is in a range of 5 to 15 milligrams, and C for 30 milligram per day is the total dose in divided doses, while for methimazole it is 20 milligrams per day in divided doses. And these carbimazole and methimazole can be given in the second and third trimester. They can cross the placenta. They can be teratogenic and also causes granulocytosis, but the hepatic dysfunction is lesser in case of carbimazole and methimazole. Now coming to the monitoring of dosages, serum TSH is measured every 4 to 6 weeks, more frequently immediately after switching to antithyroid drugs, and maintained within trimester specific ranges. Free T4 concentration maintained just above the limit of the normal. So here in the hyperthyroid patient, we have to do a complete thyroid profile. We have to measure her free T3, free T4 levels, and TSH is also done, and it should be done every 4 weeks. Now, what is gestational transient thyrotoxicosis? This gestational transient thyrotoxicosis occurs due to hyperemesis gravidarum, and the transient biochemical features is seen in 2 to 15% of early pregnancy. So, what happens in hyperemesis gravidarum? There is increase in the serum T4 levels and low TSH levels. So, the free serum T4 levels are high and the TSH is low, and this occurs due to stimulation of thyroid stimulating hormone receptors by HCG that leads to gestational transient thyrotoxicosis. And in these conditions, no medications are required, but a closed DD is Graves' disease, and no stigmata of Graves' disease, self-limiting mild disorder, and symptoms of emesis favor the diagnosis. So in every patient presenting with hyperemesis gravidarum, we have to offer her the thyroid profile test to rule out Graves' disease. Now, what is subclinical hyperthyroidism? In this condition, the TSH is abnormally low, but when you measure the T3 and T4 levels, they are normal. So, the just TSH is low on the lower side and T4, T3 are normal. So, the long-term effects of this is that this is also a hyperthyroid condition, but the hormones are in a normal range. So, this can lead to osteoporosis, cardiovascular morbidity, progression of overt hyperthyroidism or thyroid failure. Treatment is not required, only surveillance, and approximately half eventually have normal thyroid concentrations. Now, what is overt hypothyroidism? So, in 0.2 to 1.2% of the pregnancies, they are complicated by overt or symptomatic hypothyroidism. In India, the prevalence is around 5 to 12%, and another study has reported the prevalence of hypothyroidism is around 12%, which is 3% for overt hypothyroidism and 9% for subclinical hypothyroidism. So this we have to remember that the total cases are around 12%, in which the 3% cases are of overt hypothyroidism and 9% cases are from subclinical hypothyroidism. The causes includes the iodine deficiency, Hashimoto's thyroiditis, post-ablative Graves' disease. So what are the symptoms of hypothyroidism? So the patient can present with muscle pain, tenderness, stiffness, pain, stiffness or swelling of the joints, heavier than normal or irregular menstrual cramps. So these patients can have irregular menses or there is hypomenorrhea. The hair are thin, so there is thinning of hair, slowed heart rate, depression, impaired memory, enlarged thyroid gland, fatigue, increased sensitivity to cold, constipation, dry skin, weight gain, puffy face, hoarseness of voice, muscle weakness, elevated blood cholesterol levels. So these are the features of hypothyroidism. So what are the maternal, fetal and the neonatal effects? The maternal effects includes anemia and congestive heart failure, preeclampsia, placental abnormalities, low birth weight infants, postpartum hemorrhage, and the muscle pain associated with myopathy. While the fetal effects includes the cognitive impairment, neurological abnormalities, developmental abnormalities, congenital hypothyroidism, the neonatal effects can be hyperbilirubinemia and the respiratory distress. So this hypothyroidism is associated with congenital hypothyroidism also. Now the images on the right side are showing untreated congenital hypothyroidism in which the baby has presented with jaundice, poor feeding, there is hypotonia, you can see a big tongue which is covering whole of his oral cavity, and this is macroglossia. The fontanelles are larger in size and there is delayed closure of the fontanelles, and the coarse facial features are present. There is mental retardation also, and the babies are of short stature. So these are the side effects of congenital hypothyroidism. So how will you make a diagnosis of hypothyroidism? So in hypothyroidism, serum TSH levels are more and the T3 T4 levels are on the lower side. So the gland is not forming hormones in a normal range, hence the signal goes to the hypothalamus and the TSH is increased, hence the TSH levels are on the higher side and the T4 is on the lower side. So how will you make a diagnosis of overt hypothyroidism? So elevated trimester specific TSH recommendations are that in first trimester, if the level should be less than 2.5 milli-international unit per ml, and in second and third trimester the level should be less than 3 milli-international unit per ml. And in this patient there is serum TSH levels more than 2.5 in the first trimester and more than 3 in the second and third trimester. And when you check the free T4 concentration, in the first trimester the free T4 concentration is less than 0.7, and in second and third trimester the free T4 concentration is less than 0.5 nanogram per ml. Now thyroid analyte testing should be performed on symptomatic women and those personal or family history of thyroid disease or those one with type 1 diabetes mellitus. So what are the indications of doing a thyroid profile? So if there are symptoms of thyroid gland, and if there is personal history of thyroid disorder, if there is family history of thyroid disorder, and if the patient is having type 1 diabetes mellitus which occurs due to autoimmune disease, and thyroid disorder, hypothyroidism is also due to autoimmune cause, so we have to advise these patients with thyroid profile testing. Now according to Foxy, regular TSH monitoring, that is approximately every 4 to 6 weeks until mid gestation and at least once near 28 week gestation should be done. So Foxy recommends regular TSH monitoring because India comes in a endemic thyroid zone. Now ATA, also known as the American Thyroid Association, recommends the treatment of overt hypothyroidism and subclinical hypothyroidism with positive TPO antibodies. Regular TSH monitoring is advised in euthyroid TPO positive patients throughout the pregnancy, and subclinical hypothyroidism in pregnant female who have not been treated initially should be monitored every 4 weeks with serum T4 and TSH levels approximately until 16 to 20 weeks of gestation and at least between 26 to 32 weeks of gestation. So universal versus high risk approach for screening tells that if there are high risk factors for hypothyroidism, then we have to screen the patient and treat her for the hypothyroidism in pregnancy. So what are the high risk factors? So if the female is residing in an area of known moderate to severe iodine deficiency, so you can check on the map that in the northern area, so these are the northwest areas which are the endemic zone of iodine deficiency. So these patients are coming under high risk category. And if the patient's if patient is having obesity, means her BMI is more than 30 kilogram per meter square, and it could be a pre-pregnancy or the first trimester body mass index. If there is history of prior thyroid dysfunction or prior thyroid surgery, if the symptoms of thyroid dysfunction or the presence of goiter is there, history of thyroid dysfunction in the first degree relatives, means the parents, siblings or the children, if there is history of mental retardation in the family or the previous birth, if the patient is a known case of autoimmune disease like type 1 diabetes, systemic lupus erythematosus, rheumatoid arthritis, Addison's disease and the celiac disease, if there is history of recurrent miscarriages, preterm delivery, intrauterine demise, preeclampsia, eclampsia, abruption, history of infertility is there even after 1 year of unprotected intercourse. There is use of amiodarone and lithium and a recent administration of iodinated radiologic contrast. So what are the indication? Let's revise it again. If the patient belongs to a hypothyroid endemic zone. Second is obese patient. Then coming to history, if there is history in the patient with prior thyroid destruction of prior surgery, if there is family history, if there is family history of mental retardation of previous birth, or if the first degree relative is hypothyroid, if there is history of recurrent pregnancy loss, preterm birth, IUDs, preeclampsias and abruption, if there is history of infertility, and if the patient is having a autoimmune disease like type 1 diabetes mellitus, SLE, RA, Addison's disease, celiac disease, etc. And in case of drugs like amiodarone and lithium, or the recent administration of iodine radiological contrast. So these are the high risk factor for hypothyroidism, and in these patients we have to do a thyroid screening test. Now what is the treatment of hypothyroidism? So the oral replacement therapy for overt hypothyroidism beginning with levothyroxine in a dose of 1 to 2 microgram per kg per day or 100 microgram daily is recommended. So what we do, we start the patient on levothyroxine and the dose is 1 to 2 micrograms per kg per day. And women after thyroidectomy or radioiodine therapy are needed higher doses, and for repeat surveillance, TSH levels are measured at 4-week intervals in the first half of pregnancy and at once in the third trimester. Or if you are not measuring it through 1 to 2 micrograms per kg per day, then you can directly start the dose of 25 microgram with of 25 to 50 microgram increments until serum TSH values approximates 2.5 milli-international per unit. So a target of 2.5 milli-international per unit per liter is taken, and we have to adjust the dose till it comes in this reference range. So all women with hypothyroidism should undergo TSH testing at the initiation of prenatal care and subsequent indicated dose adjustment. TSH determinations are repeated in each trimester. So this is the chart for treatment of hypothyroidism in pregnancy and postpartum period based on the serum TSH values. So in the first trimester, if the levels, so first one is if the levels are less than 2.5 in the first trimester and less than 3 in the second and third trimester. So no treatment is recommended. It is coming in the normal range. If the level is between 2.5 to 10 milli-international unit per liter or 3 to 10 in the second and third trimester, means the level is less than 10. So what we start the patient on 25 microgram of levothyroxine per day, and no treatment is required in the postpartum period, and this patient is coming under the category of subclinical hypothyroidism. If the level is more than 10 milli-international unit per liter in any trimester, then directly we have to start a dose of 50 micrograms levothyroxine per day, and same dose to be continued in the postpartum period also. If the pregnant women on treatment for hypothyroidism before pregnancy and means patient is a case of overt hypothyroidism, then levothyroxine dose is to be modified according to 2 and 3, and pre-pregnancy dose of levothyroxine is to be continued in the postpartum period. And when we start the dose of levothyroxine, then repeat thyroid stimulating hormone surveillance is done 6 weeks postpartum, and we have to adjust the dose according to the serum TSH value. Now what is subclinical hypothyroidism? So this is common, but the incidence depends on the race, age, dietary iodine intake, serum thyroid hormone threshold value. Incidence is around 2.3%. So what we have previously seen, that the total cases of hypothyroidism in India in pregnancy is around 12%, where the 3% cases are of overt hypothyroidism, while the rest 9% cases are coming under subclinical hypothyroidism. So what happens here, that the T4 value is normal, but the TSH is on the higher side, and this is also associated with preeclampsia, twice risk, abruption, cardiac dysfunction, low birth weight, preterm delivery, mentally retarded baby, stillbirths, and universal screening is not recommended, but according to ATA we have to screen the patients under high risk category. So after levothyroxine therapy, if the TSH is still more than 10 milli-international unit per liter and the TPO antibodies are positive, we have to advise them levothyroxine therapy. And if the female TSH is between 4 to 10, then levothyroxine therapy is started. Now, what is euthyroid autoimmune thyroid disease? Autoantibodies to thyroid peroxidase enzyme and thyroglobulin have been identified, but euthyroid incidence is 2 to 17%. It is 2 to 5 times increased risk of early pregnancy loss, preterm delivery, placental abruption, and postpartum thyroiditis. And euthyroid pregnant women means her hormones are normal but the antibodies are positive. So these measurements have to be repeated along with the serum TSH concentration after 4 weeks through mid pregnancy. What is postpartum thyroiditis? This is a transient autoimmune thyroiditis seen in 5 to 15% patients during the first year after childbirth. So after childbirth, in the first year, there are 5 to 15% cases that can present with postpartum thyroiditis. Its onset is within 12 months. Postpartum thyroid dysfunction is seen, including hyperthyroidism, hypothyroidism, or there can be both presentations also. So the routine thyroid autoantibody testing is not recommended. The presentation varies, and classically 2 clinical phases that may develop in succession are recognized. The first and the earliest is destruction induced thyrotoxicosis with symptoms from excessive release of the hormone from glandular disruption, onset abrupt onset, small painless goiter, palpitations, fatigue that lasts for few months. Thionamides are ineffective, and if the symptoms are severe, beta blocker can also be given. So what happens, there is autoimmune destruction of the thyroid gland, and when there is destruction, the thyroid follicles are getting destroyed and they release the thyroid hormones into the circulation. So this presents with initial stage of thyrotoxicosis followed by a period of hypothyroidism due to due to destruction. So in the initial phases, what we can advise, because patient can present with thyroid storm, so beta blockers can be given, and if the symptoms are severe, beta blockers have to be given for sure. Now in the second and the last phase, where there is hypothyroid like stage, there is more prominent thyromegaly, and the management is levothyroxine placement in a dose of 25 to 75 micrograms per day, and it is given for 6 to 12 months. Then we measure serum TSH and anti-TPO antibody levels again at 6 to 12 months, and there is risk of permanent hypothyroidism, and progression rate is around 3.6%. So hyperthyroid phase should be differentiated from Graves' disease. So because both these patients presents with hyperthyroidism features, that is postpartum thyroiditis, but in the postpartum thyroiditis, initially there is thyroid storm within 3 months of the delivery, and in Graves' disease more than 6 months post delivery there are feature of hyperthyroidism. Postpartum thyroiditis symptoms are mild, while the symptoms are more symptomatic in case of Graves' disease. There can be thyroid enlargement also, and ocular signs are also seen. When we check the free T3, free T4 levels, in Graves' disease T3 levels are more, and while in postpartum thyroiditis free T4 levels are more. Thyroid antibodies are seen in case of Graves' disease, while they are absent in case of postpartum thyroiditis. Now management for postpartum thyroiditis includes, if the patient is asymptomatic and there is mildly abnormal thyroid function test, then in majority of the cases we do not offer treatment, we just monitor them with 4 to 6 weekly thyroid function test. And if the patient is having hypothyroidism, means the serum TSH levels are increased but they are less than 10 milli international unit per liter, then no treatment is needed unless planning another pregnancy. But if the patient is symptomatic, means the levels are on the higher side for free T3, free T4 hormones, and the serum TSH is very low, then these patients can be treated with a beta blocker in a dose of 40 to 120 milligrams. Propranolol can be given for heart rate control, and cardioselective beta blockers like atenolol, metoprolol 25 to 50 milligrams per day can also be advised until serum T3, serum T4 concentration normalizes. And if the woman is breastfeeding, then atenolol and metoprolol not to be given, propranolol is preferred. If the patient is in the second phase, means in the hypothyroid phase, and the serum TSH levels are more than 10, then we have to start levothyroxine in a dose of 50 to 100 micrograms per day, and we have to adjust the dose according to the serum TSH values. Now there is one disease known as a nodular thyroid disease. So what happens in this disease? There are thyroid nodules which are palpable, and they are seen in around 5% of the reproductive aged women. Management of palpable thyroid nodule during pregnancy depends on the gestational age and the mass size, and these because under the effect of hormones, these nodules enlarges in the pregnancy, and they did not regress postpartum. When we biopsy them, and biopsy is recommended if the size of this nodule is more than 5 mm and this nodule has persisted for 3 months. Usually showed nodular hyperplasia. The biopsy suggests nodular hyperplasia, and in 95% of the cases these nodules are benign. Evaluation of thyroid nodules are same in pregnant and non-pregnant women, but in pregnancy radioiodine scanning is contraindicated. So sonographic examination, if it is telling that the size of the nodule is 5 mm or more than that, then we have to advise a FNAC or a fine needle aspiration biopsy for the follicular lesion, and if there is malignancy, then surgery may be recommended. So according to American Association of Clinical Endocrinologists, sonographic characteristics association with malignancy can be a hypoechogenic pattern, margins irregular, microcalcifications, and fine needle aspirations under ultrasound guidance are the excellent assessment method. Thyroid malignancy detected in the first and second trimester. Thyroidectomy can be performed in the second trimester but before third trimester. So what is the management of postpartum thyroid hypothyroidism? Means patient has delivered, she was on hypothyroid drug during pregnancy, and now she has delivered, and according to Foxy, post delivery the patient should be reverted back to the pre-pregnancy dose. So if the patient is of overt hypothyroidism, then we have to start her pre-pregnancy value for levothyroxine hormone, and the serum TSH levels are checked around 4 to 6 weeks after delivery, and such women are the candidates for discontinuing LT4, especially if the LT4 dose is less than 50 micrograms per day. If the LT4 is discontinued, serum TSH should be evaluated after 6 weeks with thyroid autoimmunity needing annual monitoring with TSH. So how will you manage a patient of thyroid storm and thyrotoxic heart failure? So what is thyroid storm? There is excess of thyroid hormones in the bloodstream, and then which can cause a hypermetabolic state and the symptoms. So this is an acute life-threatening situation in which the patient presents with hypermetabolic state, and the pregnant patient with thyrotoxicosis can have minimal cardiac reserve. There is decompensation. This can lead to congestive heart failure, chances of preeclampsia, anemia, sepsis, and these combination can be decompensating for the patient. So this also causes thyroxine induced cardiomyopathy and pulmonary hypertension, but with the control of hormone levels, these effects are quite reversible. So what we do, that in the management, first we have to admit the patient in ICU care an hour or two after initial thiamide administration. So we have to give thiamide drugs which are propylthiouracil or carbimazepine. Iodide is also given to inhibit the thyroid release of T3 and T4. So iodide is what? Iodide is the release inhibitor, and this can be given IV as sodium iodide or orally as either saturated solution of potassium iodide or the Lugol solution. With a history of iodide induced anaphylaxis, lithium carbonate is preferred in a dose of 300 mg TDS. Coexisting severe preeclampsia, infection, anemia is aggressively managed before the delivery is considered. So this chart suggests the management of thyroid storm. So first we have to start the patient on thiamides, and heart rate control through propranolol is done. So what thiamides can be given? The preferred drug is propylthiouracil, either peroral or nasogastric tubing. So initially we have to give a loading dose. So what is the loading dose of PTU? Loading dose is 1000 milligram, and then we start 200 milligram TDS dose per oral or through nasogastric tube. While for propranolol is given in a dose of 10 to 40 milligrams TDS, and after 1 to 2 hours of thiamide therapy, we can start the sodium iodide 1000 milligrams IV TDS, potassium iodide or the Lugol solution, and in case of iodine anaphylaxis, lithium carbonate can be given. And if through these drugs, means thiamides, propranolol and the iodide therapy, the disease is not getting controlled, then we have to start the patient on corticosteroid therapy for 24 hours. Dexamethasone 2 milligrams IV every 6 hours or hydrocortisone 100 milligrams IV every 8 hours is recommended. So these are the levels of thyroid stimulating hormone in a non-pregnant and a pregnant patient. Thank you.